Okay, thank you very much. And thank you for the opportunity to be at this conference. I am at the heels of Christine's talk, which is fantastic because she's just covered a lot of different aspects of looking at this. And I appreciate the intersection of clinical applications of modeling and the reason why we do this, and what are the populations that we're trying to target, and the different aspects of ways to improve upon impairments and disabilities. And so uniquely to the University of Minnesota, we have actually 7 different faculty who are doing pediatric non-invasive brain stimulation. So you've got 2 of us today speaking, and we're speaking about 2 different aspects of it and two different aspects of computational modeling. But I think that the intersection and the blend will be a nice way to see how we've been integrating computational modeling. So my work is in pediatric brain injury, meaning stroke early on, and I will talk about the intersection of that and computational modeling. So we combine neuromodulation, neuroimaging, and neurorehabilitation. So I am a neuroscientist, and I am also a physical therapist of 30 years. So we do trials at adjuvantly integrating neuromodulation interventions along with neurorehabilitation, such as the pictures that you're seeing on the right-hand side. We have camps in the summertime and in the winter where kids come from across the United States and participate in camps where these kids are involved in non-invasive brain stimulation interventions and intensive rehabilitation after stroke. Stroke is a common cause actually of cerebral palsy. Many of you may know that, but if you see someone with cerebral palsy, commonly the reason they have this secondary diagnosis of cerebral palsy is because of stroke. And so there is a large group of individuals who have motor disability in childhood due to cerebral palsy, and the lifetime cost of care is quite expensive. And so for us in rehabilitation and in neuroscience, looking for ways to both decrease the cost of care and try to influence the developing and recovering brain early at a time of great neuroplastic activity is really important for lifelong outcomes and potentially maximizing independence with these individuals as well. So on the bottom, I show 2 different MRI slides, transverse sections of different individuals who participated in our studies in our lab. And so this is a bit different in terms of looking at the typical topography, morphology, and anatomy that you might see with the T1, T2 series. And here you're seeing T1s in 2 different individuals who had a stroke. So if you think about attempting to use computational modeling and trying to use things like NIBS to guide us in terms of what we're doing, we have the added complexity and challenge of the lesion that is actually quite variable and heterogeneous, and I'll speak about that as well. Christine so nicely already described pediatric non-invasive brain stimulation in terms of the ways that we use it. So here are 2 photos of children within our lab, one who's receiving TMS integrated with stereotactic neuronavigation to test cortical excitability, look at the neurophysiology. And then also we use TMS repetitively, or TDCS, to modify the physiology and performance. And many of you are obviously familiar with those types of interventions. So we do these currently, these investigations in kids who are ages 6 to young adults of 21 years old, but we've now been doing new frontiers into newborns, and I will speak about that in just a second as well. One key way that we can investigate the pediatric brain and the recovery is using TMS to test the integrity of the cortical spinal tract and other systems to look at motor evoked potentials from each hemisphere. So on the left-hand side, you see an individual who actually reorganized in that TMS evokes a motor evoked potential in bilateral hands. So there's a bilateral hand response. But when we do that TMS on the other side of the brain where there's that large lesion, we weren't able to elicit a contralateral response. So we categorize the circuitry of these individuals in terms of whether or not there is a response contralaterally from evaluation using TMS on the ipsilateral hemisphere. This comes in handy in terms of understanding, first of all, not only how they're wired, but also how they might respond to specific interventions, such as that constraint-induced therapy, that intensive rehabilitation, and the questions about whether or not those who might have retained that crossed cortical spinal tract integrity may actually also benefit greatly or more so from constraint-induced therapy? And those are the questions that we're asking now. So why computational modeling? And with full disclosure, I actually team with Dr. Opitz's lab as well for some of our studies, and we'll talk about that. And I actually heard some previous discussions in the morning session about this as well. So it blends with what we think and how we integrate computational modeling. So if I look at this from the perspective of different objectives, we plan specific montages, TDCS, based on some of the information that we can integrate from computational modeling. And we also would like to use modeling to understand the current strength distributed in the brain, and that was mentioned before as well. We also use computational modeling to streamline individual approaches in heterogeneous populations such as stroke. So such as the stroke during infancy. And as was mentioned, and the NIH initiatives, we're addressing that precision medicine and how to transfer this knowledge to clinical populations. So we also are involved in running parallel protocols, multi-center studies to perform meta-analysis, because as Dr. Opitz mentioned earlier on today as well, a lot of these studies are small based on the intensity and the cost and the time that it takes to run these type of studies, and you're working with a pediatric population. So you may be working with a population who from time to time are not as compliant in the ways that we think of running adult studies. And then the tertiary objectives also are to correlate the outcomes between what is modeled and what we have found in terms of TMS cortical mapping using stereotactic neuronavigation. So if we can have that precision, and we can have some confidence in terms of where we are and what we're doing, we can be able to model and also look at the neurophysiologic outcomes and meld those ideas. So I'll give you a couple examples for the primary objectives. Planning a montage such as TDCS, you have two different children who are working with us in our lab here pictured. One has an M1SO montage, and the other has a bilateral hemispheric, so a bihemispheric montage. And the positioning of those electrodes and the discussions that were, I'm sure, forthcoming and also have just been had today, truly electrode size and placement has a lot to do with potentially what type of intensity and signal is going to be impressed upon that young and developing brain. And then also in terms of current strength and understanding, what are the settings that you're using for the type of stimulation that you're imparting and integrating within these different sessions. Also, understanding the current strength in the brain becomes very important when you think about vulnerable populations, such as this individual who is actually a participant in one of our studies. So she survived a stroke in the NICU, and when she was older, meaning 6 months of age corrected for her prematurity, we assessed her brain excitability. So for us to understand what is the current strength in the brain is really important for us in this vulnerable and very young population, in addition to what Christine had mentioned with anatomical differences and changes that occur very rapidly during these young age frames. In addition to that, we also have different grades or severity of the diagnosis in terms of the impact on the anatomy and then the resultant physiology or motor function that will result after stroke. So computational modeling can guide us in terms of what we're doing with that. This is a figure from one of our publications. These are participants in one of our studies. You can see the heterogeneity of the lesion. And you can imagine that streamlining individual approaches for all of these different individuals with lesion locations and burdens that are variant throughout a study is very important. And so for us to be able to address and transfer the knowledge that we learn from bench to bedside, literally to these children who are pictured here, all of their brains, to clinical populations, modeling becomes very important for us as well, to add to our arsenal of understanding of what is happening when we are integrating non-invasive brain stimulation, and the ability actually also to, in broader scope, do a meta-analysis as I discussed. From a tertiary perspective also, how do you correlate the outcomes between what we've modeled and what we found by other means? So this is an individual who we're evaluating with using TMS, and we can look at what are the areas of cortical excitability, and specifically for this, what are the areas using stereotactic neuronavigation, specifically through those through the location and those targets, that will elicit a motor evoked potential in an intrinsic hand muscle or a forearm muscle? And before and after an intervention, is there a change or is there a variation in terms of that location and the intensity of the signal? So if we can use both the computational modeling and our cortical mapping to show that those two areas overlap, we've now strengthened also our confidence in terms of what we're understanding when we're predicting what's going to happen with the influence of our non-invasive brain stimulation. So directly intersecting a neuromodulation with pediatrics, I'm just going to give a quick glimpse of some of our studies and things that we've done in the past. This is a study that was funded by an Obama stimulus package, a challenge grant, and we integrated repetitive TMS and that constraint-induced therapy, wherein we casted the less affected limb and worked on the more affected hemiparetic upper extremity in intense therapy alternating days. And through this, we saw an improvement, a significant improvement in hand function between those children who received the real brain stimulation and those who received the sham brain stimulation. And so that improvement actually lends well in terms of what they can do from a functional perspective with their activities of daily living and moving on to their own personal goals as they grow. We took this study, integrate and expand into another study funded by a K01 and looked at transcranial direct current stimulation and constraint-induced therapy. So again, we were integrating these two, intensive neurorehabilitation with non-invasive brain stimulation in this population, again, a camp-style setting. And what we found in this study was that both groups demonstrated a significant difference in hand function, even with the sham brain stimulation, but they were combined with intensive rehabilitation. But importantly, we also showed that children with this preserved cortical spinal tract circuitry from the lesion hemisphere compared to those without showed greater improvement in hand function. So that gave us an idea about circuitry. What would have at that time been very helpful in the past is to also integrate modeling, which we were not able to do at that time, to be able to overlap and see where was that potential region of influence, the electric field and the current density and such. So we've now moved on and we're looking at integrating MRI, TMS, and motor assessments in infants, during infancy. And so we have now run a small pilot of individuals of children who had stroke either in their third trimester or up to 28 days after birth. And what we found in using TMS specifically is that the present MEP responses from the more affected hemisphere, there were present MEP responses, meaning we could elicit a motor evoked potential from the more affected hemisphere in younger individuals, but not so much in older individuals, older being 7 to 12 months corrected age. So younger in this population was really important in terms of trying to look at, can we elicit a motor evoked potential during this time of recovery and development? We also found that those children who had more atypical motor function had greater prevalence of absent motor evoked potentials as well. And so this gave us a lot of information in terms of how could we integrate computational modeling to let us understand further. So we took this down. These are some of the present studies that were either in process or just completing. Dr. Sam Nemenich, who is a postdoctoral fellow in our lab, he looked just recently at targeting a nodal TDCS based on stratifying children specifically with cortical spinal tract integrity. So that crossed cortical spinal tract integrity was present, and looked at one session of TDCS with hand training and looked at the methodology in terms of the intensity of the signal and evaluated the neurophysiology in 15-minute increments after that first intervention, that one-time intervention. And he is in the process of actually working and preparing this manuscript for publication. So to give just a couple of highlights, 5 of the 8 children showed an increase in MEP amplitude, an average of 40% increase. And also we demonstrated that anodal TDCS can alter the excitability of the contralateral and ipsilateral CST projections to the paretic hand. So looking specifically at one session, but looking at what is the influence of that one session of PDCS, and then also the signal thereafter. This is one of the integrations that we've done with Dr. Opitz and his lab in terms of looking at individual lesions that are segmented and incorporated into realistic head models. and then modeling the current density and the location from non-invasive brain stimulation. So this also works to inform us for future studies as to what are we seeing with these individuals with these lesions in terms of the segmentation and the incorporation into realistic head models, and where might we target in the future what's happening when we apply non-invasive brain stimulation in this population. Dr. Daniel Lynch is another postdoctoral fellow in my lab, and this is a study that is funded by an NIH R21, now looking at 20 infants from that original data and trying to integrate MRI, the stereotactic neuronavigation TMS, and the computational modeling to look at what is happening with the correlation and the intersect, specifically between the signal that we're getting through neuroimaging and TMS with the computational modeling aspect as well. Ellen Souter is a PhD student in my lab who just completed her DPT degree, and she is actually looking at some of the responses that we've had to COVID. So we're actually integrating surveys, emailing to the parents and the caregivers of children with childhood onset disabilities to understand the impact in terms of how it might have decreased access to rehabilitation services. And this will become important in another study that I'm going to mention in the response to COVID that we're currently getting off the ground as well. This is Emma Simpson, who's an undergraduate student in my lab. She is making, she has done a publication and translating publications that we all talk about and share into lay language summaries. This becomes important in computational modeling as well, and I'll talk about that at the very end. But for our ability to explain, as a question was for Christine as well, to our participants and pediatrics also to their families and caregivers, what are we actually finding, and can we relay that to them in lay language so that we can understand and communicate what is the impact of the non-invasive brain stimulation that we do. So our new frontiers, again, Ellen is describing here, is there the possibility of what is the optimal window for intervention in these infants with perinatal stroke? So TMS might be able to be used to understand and probe reorganization, but now that we can detect cerebral palsy earlier, is there a window there of intervention using non-invasive brain stimulation in a safe and effective manner that could actually optimize the outcomes that are happening for these children, both when they're young and for a lifetime? And then this is her explanation of TDCS specifically in terms of looking at what might be the optimal montage, but modeling would actually provide an exploration supporting the initial safety assessment and future study design. And as you can imagine, running an infant stroke study, really in terms of integrating computational modeling, as was discussed before, is very important for us to show and support. Here's where we're anticipating, here's where we are modeling the impact of our non-invasive brain stimulation, and here's where we found it in our pilot to strengthen our studies and to allow us more confidence moving forward. Dr. Lynch is also studying beyond the primary motor cortex. So Christine spoke about other areas of the brain. We have most typically investigated the primary motor area, but now Dr. Lynch is also talking about supplemental motor areas in perinatal stroke and pediatric stroke, and looking at expanding into other brain regions, wherein that modeling may help us as well to understand what's happening in areas where we may not elicit such a strong motor evoked potential, but be able to understand the influence again of non-invasive brain stimulation. And this is one more study that we're just getting off the ground in response to COVID, is actually trying to use neuromodulation and assess the feasibility of remotely monitored TDCS in pediatrics. So right now we're working with families who are not naive, who have actually participated before in our studies, trying to work with the reliability of being able to determine the motor cortex location, prepare the electrodes and the TDCS, and then to look at behavioral outcomes before we start doing a full TDCS study in the home setting. So our new frontiers and the intersect with the pediatric brain and computational modeling is the importance of that electric field estimation, the correlation with TMS, cortical excitability, mapping outcomes and behavior. Also, how do we individualize our clinical NIBS applications to try to keep these individuals, pediatric individuals, children safe, but also improve efficacy. And then trying to show as well that we are doing as much as we can to understand the safety of our assessment in this heterogeneous population, and be able to communicate with the public in terms of the families and children with whom we work. So when we are speaking with our families and when we are working towards recruitment, you can imagine that recruiting for a non-invasive brain stimulation in a population that has already been considered vulnerable and has had a stroke, those are intensive conversations with families. And when we can sit down and show them what we have learned preliminarily by our computational modeling, they start to understand that we have, of course, looked further into where would the influence of this brain stimulation be, and do we understand the potential impact and the safety that this would have for their child. So not only does the family want the best for their child in terms of outcomes, of course they're looking for how safe is this and what do you know before we even put that stimulator on our child's head, and how can we describe in lay language, such as we are doing with those applications with our publications, to improve our recruitment and our enrollment in our studies. I want to thank all of my current lab members and our collaborators, both internal at the University of Minnesota and externally, and to Dr. Opitz and his team for the invitation to speak to you today. I'll take any questions. Thank you.
Thank you, Bernadette. It seems like your talk was so polished that audience still thinking about the question they would like to hear. However, I would like to follow on some discussion that was already happened today. You're obviously doing like pediatric rehabilitation for a long time, and before you did it maybe without such extensive involvement of modeling. Now you use it way more. Have you already saw improvement in clinical outcomes thanks to modeling, or what is your projected added benefit of modeling in the business?
So as Christine had alluded to, currently there is not an FDA approval for clinical applications for TDCS or RTMS in these children. There is for depression, and that had been mentioned before as well. But we are looking to try to do more multi-center studies and meta-analyses so that we can support the clinical applications and have this be covered by insurance and have this be integrated. There have been good outcomes that we've seen and some improvements, specifically significant improvements, like I said, in hand function. But those need to continue to be explored on a broader scope with more participants so that we can actually look towards using this clinically. It is the first question that every family usually asks us. I guess I should say the first one is it safe? The second one is it helpful? And so that question that you just asked me is really fundamental towards looking at the outcomes that we have in pediatric stroke. So thank you for that question.
And I guess you already can tell safely that it is safe. So now we are looking in multi-scale, right?
We can, and we actually, we have families from around the world email us and call us saying that they would like to use non-invasive brain stimulation on their child's head, and they've read our articles, and so they're going to put it on their child's head, and have they done it correctly? So when we say, is it safe? It's safe in what we've investigated in the research that we have, and we need to do more investigations to be able to understand at what intensities and in what specific regions of the brain so that we can be able to use it most efficaciously. But I do agree with you in terms of what we've been doing. We have not had any serious adverse events in working with over 200 children and thousands of stimulations. We have not had any seizures, no serious adverse events, and have been able to mitigate the minor adverse events that have occurred as well.
Thank you. A few questions from the audience. Okay, more than few. First, I think this question that's related to what we just discussed. Do you think taking a stressful MRI scan is beneficial enough for children in order to individualize the intervention by using computational modeling?
I think that question actually was asked to Christine, but I saw it at the end of her talk. But I think it actually applies to both of us. Yes. So I think it's worth it if we can do it. And there are ways. I mean, if we have a T1 anatomical or we have anatomicals, it is nice for the precision and the confidence in moving forward and understanding, especially in a population who has a anatomical lesion as such. and such changes in head size and brain size as they're developing, I think it's really important for us to be able to do that. We do have ways, and we've been able to work even with the Baby Connect project that's been able to find ways to keep babies and infants and children and young adults safe and confident in the MRI and be able to do it. It is a lot, but it is worth it. And most children find that a great opportunity to watch the Puppy Bowl or their favorite movie or listen to their favorite music, and they actually do quite well. Sometimes I would say much better than adults do in MRI. The infants, we do not use sedation, we use natural sleeping protocols. So we actually do late night scanning where the baby is asleep and in the scanner and is safe, and it has worked quite well. So I think it's worth it if you can do it. There was mentioned before by another speaker, I believe it was Alec, who was talking about the potential of not needing neuroimaging if you can't get it, but how important it might be to improve our confidence and be able to understand the implications of our work.
Thank you. Next question. Given that many of the therapeutic effects of TDCS to date are from task-based engagement of the relevant neuronal circuits and not necessarily from shaping, focusing the electric field, what practical role does focality and targeting play in clinical efficiency?
That is a very good and detailed question. Thank you for whosoever framed that. So I think it plays a very large role. And because if we're looking even at the previous speaker who was talking about where's the influence of the brain stimulation in terms of looking at even a TMS coil, I think the focality, it is quite important. And I know what you're saying in terms of the task, but it is quite important in terms of what we know for relative function in specific somotopic areas of the brain and the network activity overall. So of course there's going to be dispersion, and of course it's not going to be just focusing on one specific area, but if we can measure from that area and we can actually target and look at our computational modeling and using stereotactic neuronavigation with TMS, we can then come up with some objective data to show that we can measure the change.
Thank you. And so the final question to you, how early would you start treatment in a baby that has a clear injury or asymmetric motor reflexes?
So we don't know yet. We are investigating using TMS in babies as young as 3 months old, corrected for their prematurity. But I will say this, it's similar to the thought of doing deep brain stimulation in the subthalamic nucleus of an adult with Parkinson's. The neurosurgeons are already asking the question, is it possible to put an implanted electrode in utero when we've identified a stroke? So I don't know when too early is too early. There are already studies being done in spina bifida where they're actually, the baby is still in utero and they're closing the opening in the back in utero, and the outcomes have been significantly improved thereafter. So we are on the cusp of beginning that exploration. And I also would say the word again, safety, safety, safety is what we are primarily focused on, but there's the potential to really make a huge impact from a neuroplastic perspective early on and really improve the quality of life for individuals and those around them, their caregivers, for a lifetime. So it needs to be carefully explored and detailed and done with quite a good methodology in terms of how we come at it. That is why I think that computational modeling is imperative in terms of trying to move that forward, move those investigations forward.